Good afternoon, everybody. Welcome. Why don't we go ahead and get started? I'd like to start by welcoming all of you to the Shoolman Memorial Lectureship, made possible by a generous donation from the late Mrs. Amy Shoolman. It was Mrs. Shoolman's wish that we would create a lectureship with a focus on schizophrenia and with the goal of improving public awareness and understanding about schizophrenia. Now, before we begin, just a couple of housekeeping items. First, if you're on Zoom, please use the question and answer feature because we will be disabling the chat feature. Second, if you're here in person, please wait for the microphone before asking a question. Microphones will be distributed. And third, at the end of the presentation, there will be a QR code on the screen that will allow you to provide an evaluation for today's event. With no further ado, it is my pleasure to welcome our speaker today, Susan Abderholden, Executive Director of NAMI, Minnesota. Ms. Abderholden has a long and very distinguished history of leadership and legislative advocacy aimed at improving the lives of people with serious mental illness and their families. She began her career working as a psychiatric technician and quickly rose through the ranks, then becoming a legislative analyst for the Minnesota Hospital Association. This while earning a master's in public health administration from the University of Minnesota in 1980. Then, following work at the Minnesota Department of Health as a community planner, she served as director of ARC Minnesota from 1981 to 1991. Her advocacy culminated with her being at the White House for the signing of the Americans with Disabilities Act by President George Bush in 1990. Ms. Abderholden continued her advocacy and legislative work as deputy director of the office of Senator Paul Wellstone from 1991 through 1998, where she advised the senator on several important issues, including mental health, disability, child welfare, women's rights, and human services. She has served as executive director of NAMI, Minnesota since 2001, during which time she's continued to advocate for legislation aimed at improving the lives of people living with mental illness and their families. Now, in addition to her work as NAMI, she's served on several community boards. Just to mention a few, she served on the boards of Goodwill Easter Seals, Rainbow Health Board, Telehealth Advisory Group, Competency Restoration Advisory Committee, and the Mental Health Legislative Network, of which she serves as co-chair. Her work as a mental health advocate has been recognized by multiple agencies and organizations. To mention just a few of her many awards, she is recipient of the 2020 Wattenberg Policy Award from the University of Minnesota, the 2019 Purdy Award to End Discrimination from NAMI National, and the 2013 Advocacy Leadership Award from the National Council for Behavioral Health. She's with us today to present a lecture entitled, No One Walks Alone. Ladies and gentlemen, please join me in welcoming Susan Abderholden.
Thank you so much for that very kind and humbling introduction. So I'm supposed to quickly go through these slides so that you know them. So again, this is the title of the presentation, my affiliation, the learning objectives, and the financial relationships, which there are none, and then the accreditation statements. So what I hope you get out of the lecture today is really understanding the impact of loneliness, particularly among people with serious mental illnesses like schizophrenia and bipolar disorder, understanding the importance of engaging family members, and what are those strategies to meaningfully engage family members and friends. So the U.S. Surgeon General's report that came out in 2023 The Surgeon General actually didn't think loneliness was a big deal until he started kind of traveling around the country and listening to people and listening to their stories, where people were saying they were shouldering life's burdens by themselves, that if they disappeared tomorrow, no one would actually notice. And what he came to realize is that certainly the impacts of COVID, which isolated a lot of people, and in Minneapolis, honestly, the murder of George Floyd, which actually made many people from the BIPOC community nervous about going to certain places in public, we saw that people were actually isolating more. And so what he said in his report was, our epidemic of loneliness and isolation has been an underappreciated public health crisis that has harmed individual and societal health. Our relationships are a source of healing and well-being, hiding in plain sight, one that can help us live healthier, more fulfilled, and more productive lives. Now, they did want to make sure that we understood the difference between social isolation and loneliness. And what he said is, in terms of the impact of loneliness, is the same as smoking 15 cigarettes a day. It has the same impact on our health. And it also impacts our communities, right? Because if people are isolating and not coming together, it harms our community organizations, volunteering, even in our schools. So social isolation is really just, you don't have a lot of relationships, right? You're not joining different groups or anything like that. But loneliness is more how you feel, right? That you're feeling that you're not connected to others. And that is, of course, a difference. So what can impact loneliness? Well, we know that chronic disease or disability can, and some of that is just related to the fact that maybe you can't get out of your house very well. There's not, transportation that's accessible and things like that. Sensory, think about that, whether there's people who don't actually know sign language in your community when you go out, which makes it hard to engage with people. Or perhaps there's not accommodations when there's loud noises and things like that. Certainly, we know that mental illnesses and stress can make it hard and actually, make people feel more lonely. When you're not feeling well, you just really don't engage with other people. People who have faced discrimination, microaggressions might also feel like they don't want to go out in public and don't want to have to experience those kinds of things. When you're living in poverty, which many people with serious mental illnesses are, supplemental security income isn't very much to live on. It can be hard to go out in public to pay for transportation, to join clubs, to do those kinds of things as well. And then even just thinking about life stages, right? So you have people who are, who are not married, they just haven't found someone yet, or they're widowed or divorced. And they're forced to kind of live alone in a sense, which some people love, but not everyone does. So what they found from a lot of the research is that when you are lonely, you have a 29% increase in the risk of heart disease, 32% increase in the risk of stroke, 55% greater risk of hospital readmission. They experience higher rates of obesity, poor diabetes management, poor control of high blood pressure, 50% increase in dementia, and it can be a predictor of suicidal ideation as well. And so, I think, again, it's understanding the impact of loneliness on our whole body, not just our brain, right, but on our whole body. So when we look at, how are people connected, we want to look at the number and variety of relationships, right? So do they have 3 friends? Do they have 5 friends? Are those good friends or just acquaintances? How can we rely on those folks for needs that we might have? And how is the quality of those relationships? What we do know is that often family is actually the most important source of being connected to others. And so when we think of why family involvement can actually improve things like diabetes care, help people get better nutrition, exercise, maintain emotional stability, and actually reducing relapses, think about people in your lives that maybe have supported you. I can say that my dad had triple heart bypass surgery in 1971, when that was actually still considered, somewhat new, but he actually lived to be 84. And the reason, honestly, was absolutely due to my mother. I mean, she just wouldn't let him eat anything that was going to be bad for his heart, right? She made sure that his stress level was down. She made sure that he exercised every day, and he did live a very long life. And I really believe if my mother had not been there to support him, that he would have died a lot earlier. And so think about how families kind of impact and engage people to do better health along the way. So let's think about loneliness and mental illnesses. So we know that 50% of mental illnesses emerge by the age of 14, 75% by the age of 26. Think of the symptoms of serious mental illnesses, right? It may be hard, your thinking might be off, you have delusional thoughts. You might not be able to relate to others because of some of those symptoms, including, severe depression, even that flat affect can impact it. And if you think about most people are diagnosed with these serious illnesses by the age of 26, what young people know actually how to continue to be a friend with someone who's experienced psychosis or serious depression or their first manic episode? Young people have no idea, frankly, how to do that. And what the Surgeon General found is that the largest loneliness group was actually young adults. And I think when we think about people with serious mental illnesses, it's even going to be more. And so, again, if you have a serious mental illness, you're already going to have a harder time having friends. And many of them will just kind of disappear, frankly, when the psychosis and things like that come about. Now I want to think about how we further isolate people with mental illnesses. So how many of you have ever visited a psychiatric unit in a regular hospital? So how do people stay in touch with their family members? Is there a phone in their room that they can easily call a family member? A family member can call them? So at the point when people need others the most, right? One of the most, frankly, scariest times perhaps in your life, you can't actually connect to other people. We make it really hard. Family members try to call in and you're hoping that another patient picks up the phone and finds your family member. How hard is it to even leave a message to say, I'm thinking of you, right? I care. I want to know how you're doing. We make it almost impossible. What are the visiting hours compared to other units? Often they're more restricted. And I remember in the early 2000s, they didn't actually let parents of children visit every day because, of course, we thought that they were the cause. If you call the main number, perhaps you bring your loved one to the emergency room for a crisis, and then you call back to see if they're doing okay. They say, I'm sorry, we can't even tell you if they're here. And one of the things that I found when I came to NAMI is I would ask people with serious mental illnesses, when you were hospitalized, did you ever get a get well card? 100% no, never. And so we don't provide that kind of community support that you would for any other illness, and that further isolates people. Now I'm going to go on and on about HIPAA, but I will at least just say that HIPAA is used as a shield and not a way to support engagement with families and to people connected. Has anyone ever had a loved one in surgery? Okay, so the surgeon goes in, they come out, and whoever gathers around the surgeon, they give the information to. Did they ever say, do you have a privacy release? Are you this person? You know they don't do that, right? They don't. They just help whomever. But when it comes to mental health, we do it differently. My late husband, had at one point developed epilepsy. And so we had these seizures. We didn't know why. And I would call the neurologist and I would share with her what was going on and ask what I could do. And then he was hospitalized for a week and they discovered that he actually had non-epileptic seizures caused by serious depression. I was then voted off the island. No one would talk to me. No one would share information. No one would take my call so that I could share information. And yet this was the same man, same symptoms. It's just that at one point we called it neurology and then it was okay to talk to me. But as soon as it became mental health, then they weren't going to talk to me. And so we don't apply HIPAA equally among healthcare conditions. And that's something that we need to think about. We have people routinely discharged from a hospital with no one in the room. You all know in every other hospital unit, they tell you, have someone in the room when you're discharged because you're not going to remember what we're telling you, right? But for somehow with the mental illness, when people might have difficulty remembering, we're like, no, it's okay. You don't need to have anyone in the room. And what we know from various studies as well is that many people with mental illnesses actually have to rely on their families for support. Those friends have gone away. They have, we don't have clubhouses and things like that everywhere. So they don't have a lot of other people to depend on. And it's something that we really need to think about in terms of breaking the pattern of loneliness. And I love this. Family is family, whether it's the one you start out with, the one you end up with, or the family you gain along the way. And I really believe in actually defining family. It's not just blood relatives, okay? And when I think of my siblings and parents lived in another state, but I have very close friends who I would actually consider family. And if something happened, they're people that I could call upon. And so we want to define family very broadly, not just, related by blood. But it could be that, it's through, adoption. It could be that your kids are really close, and so then you become really close with that family. It could just be these are people in your group that are really supportive. So we want to define it broadly, and we want people to have connections to others. So sometimes I find that, there's this push to say, you're an adult now, right? But I want to think about all the ways that families support us throughout our lives. So how many of you have ever had a baby? Did your parents bring food? Did your mom come over and say, you sleep, I'll do the dishes? I know it's not all families, but for a lot of families, people help a lot when someone has a baby, right? You might have saying, I'm going to give grandma's recipe because I know it's a comfort food, so you're going to have this. If any of you have moved through college, right? How many times did your parents actually come and help? I'm not even going to count the number of apartments I cleaned out for my daughters when they moved out of their apartments, right? But, as family, however broadly you define it, you come and help with those kinds of things. Financial emergency. Many people rely on family members, right? When there is a financial emergency, their car breaks down and they don't have money to pay for it, but they need to get to work. Following surgery, people show up with food, right? And support, do your laundry, mow the lawn, those kinds of things. And who do we gather with around holidays? So just because we're an adult doesn't mean that we're, operating alone. We still operate within a family and a community that helps us when we really need them. So call it a clan, call it a network, call it a tribe, call it a family, whatever you call it, whoever you are, you need one. None of us get through a serious mental illness or a serious illness of any kind without help. So here's what we know when it comes to families with mental illnesses. So the onset is traumatic, especially for things like bipolar and schizophrenia. It's not something you'd necessarily ever dealt with before. And so we have to understand the stressors that this places on the family. In the study that was done with NAMI and the Mental Health Association, it was called On Pins and Needles. What they found is that the majority of people receiving care were between the ages of 18 to 39. So we're probably looking at young adults with pretty serious mental illnesses. And it's often a parent taking on the care of a child. Certainly spouses and partners, parents come in, but it's more majority there. And 55% said that they were included less than they felt they should have been when talking about the care of their loved one. And so I think these are important statistics to look at. So families really in our mental health system are not encouraged to participate at all. I'm really amazed at sometimes when people are told, you have a 25-year-old with only SSI income, they're still struggling with delusional thoughts. They couldn't buy groceries if their life depended on it. And the case manager is saying to them, you're an adult, you should move out of your parents' home. Just because you're over 18 doesn't mean that you can take care of yourself. And I always like to say that 26 is the new 18 anyway. And so, we need to really kind of think about this. So I just want to know how many of you in this room live alone? There's a couple of hands, but the majority are living with someone else, right? So living on your own does not mean that that's success as an adult, but somehow our mental health system ties it to it. And it's like, if they're still living in, a group setting or with their family or, in supportive housing, they're not successful because they are not living alone. As I said before, HIPAA is used as a shield. Instead of engaging families, we use it to prevent the engagement. I like to tell mental health professionals that HIPAA does not require you to be stupid. People, need to have someone there when they're discharged from the hospital or when they're not doing well. And I think there's generally a lack of understanding of the impact of serious mental illnesses on families. And often what we see is that families are blamed for it. Now, I want to say that, if someone shows up in the emergency room, right, with a family member who maybe was in a car crash, maybe someone had a heart attack, do they appear calm? Do they appear reasonable? No. So why should a family coming in with a loved one who's experiencing a psychotic episode look calm and reasonable? It's an emergency. And we don't look like A parents when we're in a crisis, right? We look like D or F, but that doesn't mean that we are routinely bad. It means that we are in a crisis. And when you're in a crisis, you do not show your best side, right? Because you're in crisis. But we have to remember that when we have people with mental illnesses in a crisis. So here's what we hear all the time. And, some of you who are perhaps older remember the phrase, the schizophrenic mother. We used to blame mothers for schizophrenia. That was a real thing. And I think that those kind of attitudes somehow have carried over. So we hear things like the parents are being overprotective. Well, maybe they've seen their kid crash and burn. Maybe they've seen them end up interacting with police or ending up homeless. Yeah, they're protective. They've seen the worst of what can happen if the illness is untreated. They're cool or indifferent. It can be really tough, right? Especially when you feel like you've been pushed out of the situation and not been able to engage, you're kind of like giving up in a sense. Families enabled their bad behavior. So I hate things like enabling. If you had a young adult who had some rare cancer diagnosis, and so just allowed them to be at home and you took care of them, we wouldn't use the word enabling. When your kid is sick, they're sick. And parents are trying to help them in the best way that they possibly can. And pushing them out and using tough love doesn't really work well with schizophrenia or bipolar disorder. So those are words that we should really, I think, abandon. Sometimes people say parents, our families have sabotaged treatment. Well, sometimes it's really asking questions or saying, I know they tried this medication before. Why aren't you listening to me that it's not working? It's not going to work in the future. Sometimes people say, the apple doesn't fall far from the tree. This family is dysfunctional. But again, when you have a loved one with a serious mental illness and you're not sure how to move forward and our system isn't really responding to the needs, it's not that the family is dysfunctional. It's just that they can't get the help that their kid needs. And then always it must be the parent's fault. And I know when the ACEs study first came out, we had, some child protection workers using that as a list to say, here's how the parent is bad. But we have to remember that ACEs, adverse childhood experiences, was really about trying to figure out why some kids are resilient and some are not, so that we could build on resiliency, because adverse things happen and we can't actually always control that. So again, let's think about the impact of the family, which actually isolates the family as much as it does the individual. So in Minnesota, they don't say casseroles, they say hot dishes. So we call it the no hot dish illness. So your family member, whether it's your kid or, say your husband is hospitalized, no one brings you a meal. No one says, hey, can I help in some way? You're just alone. You don't get that kind of community support that you would for any other illness. And the other thing we know, because of negative public attitudes, and I don't like to use the word stigma because it's really about discrimination, but those negative public attitudes make it hard for even to share that information with other people because you're afraid about what people are going to think. And are they going to blame you in some way, right, for your kid's schizophrenia? So when these things happen, what families kind of think about are a number of things. One is they kind of just, in some ways, kind of beat themselves up, right? It's like, if I had just done this, if I had just noticed that it was depression in high school and really focused on that and just thinking it was a teenage phase, maybe they wouldn't have developed schizophrenia, right? You can just be frozen in time and just not know what to do and how to move forward. Again, that isolation that they're going to experience, kind of the embarrassment about talking about it. There's always that fear, even when they're recovery, that something's going to happen, that the symptoms are going to come back, or their symptoms are going to get worse. There's just a lot of feelings that come along with this. And then really people are worried about judgmental reactions from others. How are other people gonna see this? And I can tell you that many employers, when you have a child like under 18 who has a serious mental illness, they need to go to therapy every week. You don't actually get to take that sick time every week to take your kid to therapy. And that's why we know that when we look at the treatment completion rates for kids is low, because employers don't recognize the impact of a mental illness on a kid and their need to take off of work just as if they had to bring their kid for physical therapy or cancer treatment or whatever. And so those kinds of things also happen to families, which also make them feel more isolated and not able to actually take care of their family member. The one thing that we never talk about, I think, in the mental health system is those loss of dreams. And I'll call it ambiguous loss, right? And so, think about the age that it occurs, especially schizophrenia. So maybe they're 20 and they're off at college. You have very concrete dreams for your kids at that point, right? They're going to be an engineer. They're going to be, they're studying math or studying social work, and you have this dream for them. And all of a sudden, that dream gets dashed. That has an impact on you. You had this vision for your child, and that's not there anymore. And you have to adjust, right, your dreams for your child. And you're not even sure like what's going to happen after this, particular incident. And so that is definitely grief. I worked at ARC and with parents of kids with a developmental disability, and they pretty much knew by the age of 5 that their child had a disability. And your dreams for your kids at age 5 and 4 are pretty mushy, right? They're pretty blurry. But when your kid is 18, 19, 20, you have very concrete dreams. And again, those dreams are gone, and they have to figure out like, what's that new dream going to be? There's a huge financial burden as well. As we all know, does anyone think mental health parity is really enforced? Okay, no one should raise their hand or we're going to talk afterwards. No, it's not. It's still a dream, right? And especially when it comes to non-quantitative treatment limits, which are kind of, you're supposed to be providing like services. So if someone has a knee replacement, insurance is going to pay for them to have rehab at a nursing home. You have someone with schizophrenia ready to leave the hospital. Are they going to pay for residential treatment for 90 days? No, they're not. But why wouldn't they? Why shouldn't they, right? And so lots of times families pay out of pocket for that treatment that their loved one needs. They have a family member who may not have any income. If you've ever tried to fill out a Social Security application, you know how long, especially for disability, it takes to actually get it processed. And then it's usually, denied on the first round. So you're talking several years where that family doesn't have any income. You might have to take off as a parent, you might have to take off of work or leave your job in order to care for them, that maybe you can't leave them home alone because of suicidal ideation, right? That there's no one to take them to the appointments and things that they need. And then they're often paying for things. It might be that you're paying for rent when you're, maybe your son was doing well for a while. Now they're hospitalized. How are they going to pay for rent? And so you're putting out those dollars as well. And so in that one study, they said 49% of caregivers said their loved one is financially dependent on family or friends. So if your son or daughter develops that serious mental illness and you thought, I'm going to retire at 65, you may not be retiring at 65. Right? Because you have those additional financial burdens. And so your life has also changed in terms of when you can retire. Trying to figure out like, where are they going to live if they're not going to live with me? What happens when I die? Who's going to take care of them? And then the plans for the other family members might also be changed, especially siblings. And so maybe because you've spent so much money on treatment, you're not going to be able to provide as much support for college, for example, or some things like that. And so then there becomes a struggle, frankly, and some conflict within the family because of those competing needs. And then there's a lot of conflict about what to do. I got to tell you, families get a lot of bad advice from other people. There's tough love. There's, have you tried this particular herb? I heard these vitamins really work well with schizophrenia. People give you tons of bad advice, and it's hard to know what to do. Tough love is really a huge one that goes on all the time. Sometimes professionals paint a really somber picture, that recovery is maybe not possible. And that can create conflict in a family. You might have a mother who's like, I'm going to hang on to hope. And the father who's like, we need to be realistic about what this life is going to be like. Again, siblings can feel resentment about how they're being paid attention to versus their sibling who has a serious mental illness. And so that becomes hard too. And then again, the caregiving burden, which it truly is, because you're not expecting it, right? You're looking forward to that empty nest. If any of you have had kids who left, admit it, right? You come home and your house is the same way as when you left. So you're looking forward to that empty nest. And now this young adult is back living with you, right? And so things have obviously changed. So I think it's important to remember that mental illnesses affect the entire family, including in terms of loneliness and isolation. And I really don't believe that anyone gets through a serious healthcare condition, no matter what it is, by themselves. We rely on other people when we're not feeling well. And we need to make sure that people with mental illnesses have someone to rely on as well. In that study that was done, over 60% of people with mental illnesses said they depend on their family for support and for advocacy. And I think the other thing we all know is that it is really hard to access mental health services. It's even worse now since COVID because we know that there's been an increase in the prevalence of mental illnesses, particularly depression and anxiety. And so we have more people wanting care, right, than we have care available. I like to say that our mental health system is not broken. The reality is it's never been built. The state institutions were not a mental health system. And when you don't have private insurance paying for the care that people need, you have Medicaid that discriminates against paying for services. It's called the IMD exclusion, Institute for Mental Disease. You have Medicare only recently in January started paying for licensed professional clinical counselors. They also have a limit on the number of inpatient bed days you can have under Medicare. You know, our system can't meet the needs of people right now. And so we need families, right, to be there. And then you need to understand their frustration when they can't actually get the care that their loved one needs. So here's some reasons to involve the family. They really are an early warning system. So Ken Barlow, who is a meteorologist in Minnesota, and actually came out saying he had bipolar disorder at the NAMI walk many years ago, his wife says that she can tell just by him walking across the kitchen floor that he's going to become manic. She can tell. Family members are the canary in the coal mine. We see some of those symptoms returning before a mental health professional ever does, because we're with that person, right? We kind of know their rhythm. We know if they're using or not. We can tell you if they're using drugs or alcohol. We can usually see that, especially if they're living with us. We know the person's treatment history. And so I think family members are great, right, for being able to say, no, we tried that medication and here's what happened. No, we tried DBT, but it didn't really work. They didn't engage. And then we are the person's safety net, right? When all else fails, when nothing is working and they can't get a job, we're their safety net. The government doesn't have a very good safety net, and families are really the safety net. And then we can assist with treatment plans if we know about them. Right? We can say, oh, they're supposed to take their medication in the morning. Okay, so we'll try to encourage our family member to do that. Oh, they have to go to therapy next week. Okay, I'll put it on my calendar to make sure I can drive them there. And so, you know, again, we can be very useful in helping the person get better. So I really like this quote: when everything goes to hell, the people who stand by you without flinching, they are your family. So another reason to involve the family is you all come and go. You know, you might be at this hospital or this clinic, but maybe in 5 years, you're going to be somewhere else, but we're there. And so we can, again, provide that kind of continuity that mental health professionals can't. And I want to say, I really admire and want more mental health professionals, right? They're a very important part of our system, but you can't just do mental health professionals, right? You need the families as well. Again, we fill in where the government programs fail. Non-emergency medical transportation doesn't work in many places, especially rural areas of states. And so even if you're on Medicaid, you might not be able to get an NAMT vehicle to take you in. And then we really are there for the long haul, even if the person refuses to sign a release of information. We're still going to be there. They're our loved one. We're going to be there to protect them and support them no matter what. What we do know is if you don't engage families, you're going to see poor outcomes. And we see that over and over again. We see people with serious mental illnesses, they're ending up alone. Often they're vulnerable, especially when they're still experiencing those symptoms. They're homeless or in the criminal justice system. So we know when we look at people who are homeless, 20% are usually living with schizophrenia, and 4% of people in jail live with schizophrenia. And so when they don't have that support on the outside, and sometimes honestly, families do give up. They've tried to be engaged, try to find out where the person is, try to find out when they're leaving the hospital, and they're just never given that information. And they're like, well, I don't know what else to do. Judge Hopper in Minnesota, he was head of the mental health court in Hennepin County, and he found that most of the people who came into his court did not have involved family members. And he always wondered if we could have engaged family members earlier and helped them understood the mental illness, made sure that they were engaged with their family member, could we have kept them out of the criminal justice system, right? Could we have done that? Now, I want to say, especially related to HIPAA, families do not want the medical records. Okay, what they want to know is like how to help them. They want to reduce that kind of confusion about, so what is schizoaffective disorder? How is that different, than schizophrenia or bipolar disorder? They want to know the expectations. We still want you to give them hope, but they want to know what to expect next, right? So after that first episode of psychosis, what happens next? What should I be looking for? They want to know how to support their relative. Your high school health class did not teach you how to engage with someone with delusional thoughts. I mean, it just didn't, right? And so how we expect family members to figure out how to do that, or when someone's hearing voices, they don't know. They don't know not to tell the person your delusional thought is wrong. They don't know they shouldn't do that, right? We need to be supporting them and helping them do that. They want to make sure their loved one gets quality care. And in order to do that, they have to know what that care is. They have to know the treatment plan. And they want to make sure that you have all the information that you need. I mean, I can tell you, even with my late husband, who lived with serious depression, he wasn't telling his doctor everything, right? He wasn't telling his therapist everything, but I knew how the depression was impacting him. I saw the symptoms. I saw how it was limiting, his ability to relate to his kids and impacting his job. And I needed to share that information so that that clinician could actually use that information to help him get better. So in regards to HIPAA, and I want to say that we actually have a booklet that's online at the NAMI Minnesota site that's called Understanding Data Privacy. Lawyers are going to tell you what you can't do. We're going to tell you what you can do. And often, frankly, HIPAA is misinterpreted, just saying you can't talk to the family without a privacy release. And if the family tells you anything, you have to tell the client. One thing we noticed, and we actually worked on this in Minnesota with the Hospital Association because of the number of people who were coming back to the hospital, readmission after, before 30 days was up. And one of the things that we found is that they, and again, had no one in the room when the person was discharged. But they also only asked for the privacy release the first time when they were first getting admitted. Well, when they're first coming up from the emergency room, they might be ticked off at their family member who brought them to the emergency room. So you don't have to ask them once. You can ask them the second day and the third day and the fourth day, right? As they start to get better. It doesn't have to be a one and done. The other thing is you don't have to actually have them sign something. You can just say, hey, can I just share some information with your families, your mom and your dad, and can I share what your diagnosis is and what the treatment plan is? It doesn't have to write it down. People who are already paranoid don't want to sign something, but they might give you a verbal okay, and that really is okay under the rules. And then again, family members don't want to see the written records. They have no desire to see that at all. So when you look at HIPAA, and there's a Q&A, actually, it's if you Google HIPAA FAQs for individuals, you will see the answers to these questions. But again, you can ask the patient for verbal permission to provide information to family members. You can say before you discharge someone, we like everyone to have someone in the room when people are discharged anywhere in this hospital. Who would you like to include in the room? And that verbal okay is enough. You can also provide information if you believe it's in the patient's best interest. If you have someone who still is kind of suicidal ideation, you can tell the family in order to make sure they stay safe when they go home, right? But I think a big thing too is that you can listen to the family member's concerns and not share that information with the person. People don't think that that's true, but here is the citation. So it's Code of Federal Regulations. You can read the number, but it actually says that you don't have to share that information to the patient if you think it's going to disrupt the family's relationship. And it often will, right? But again, if you want to create a good treatment plan, you need to know some of this information that families are seeing. So things that help is really asking, who do you want to be involved in your care, right? Is it your mom? Is it your sibling? Is your dad? Who would you like to be involved in your care? Again, these are serious illnesses and no one gets through it by themselves. And it's also important to explain why, right? It can be, I know sometimes you have difficulty waking up because of the medication. If your parent knows when the appointment is, they can make sure that you get up on time and get to that appointment. And, that might seem like a small thing, but in most clinics, if someone misses 3 appointments, they can't go back to that clinic. So now they don't even have a provider anymore. So it is important that people get to those appointments. And then just to say, your parent can watch out for the reactions to the medication in a way that maybe you won't notice. People don't notice dry mouth right away, but a parent might because they're seeing them drink a lot of water, right? Which also could be a precursor for diabetes, which also occurs often with people with serious mental illnesses. So here's some ways that you can really actively involve families. One is to really help them maintain hope. And, I've been around NAMI long enough and had, way too many conversations with people who just have almost given up on hope. But I have seen people with very serious schizophrenia, including being involved with, meth and being homeless and things like that, that 30 years into this journey, they recover and they do okay. And so sometimes it does take a long time, but I really want to make sure that people hang on to hope, as difficult as that might be, because hope just helps us live life, right? And so we need to hang on to hope. Validate their worries, right? It's not just kind of brushing them off. Again, a lot about these illnesses, they don't. And so, really making sure that you're hearing their concerns and saying, that's a valid concern, or this one you don't have to worry about so much, but really engaging with them. Honest and caring communication is also important. So it's, okay, it could be a difficult time the next couple of weeks, and here's what you need to look for and watch for. But again, making sure you're talking about that. Giving them resources and information. Here's a place where you can go. I actually had one psychiatrist who said to a family member, I really can't share any information with you, but if you wanted to look up treatment for schizophrenia, here's where you should go. So not really revealing that their loved one had schizophrenia, but pointing them in a direction where they could get information in order to help their loved one. Things that they can do to help their loved one get better. And again, you shouldn't push back on delusional thoughts, but you can connect to the feelings underneath. It's like, you're not going to say, no, the police they didn't put cameras in your bedroom, right? But you can say, the family member can say, that must be scary if you think someone's watching you, right? To really connect to that feeling underneath without actually admitting to the delusional thought. We need to really respect cultural traditions. And I think that, I know at least in Minnesota, 90% of the mental health workforce is white. And so really creating a culturally diverse workforce is really important, and thinking about those additional cultural things that really help people heal. We have a large Native American population in the Twin Cities. And so, doing spirit doll workshops and doing healing circles are things that really help in terms of someone's recovery. And so really kind of thinking about that. And in some cultures, living alone is not the ideal, right? You live with your family until you get married. And so we have to make sure that we understand and respect those cultural traditions. Encouraging the family to stay involved even when their loved one doesn't want them to say, I know they're really kind of putting up this wall right now, but, hang in there, get some support, and it'll be okay. Giving them information about the Commitment Act and how it works. I know in most states it's a very frustrating act because you have to wait till someone is a danger to themselves or others, even though families can see kind of those early warning signs coming on. And then making sure they have information about the adult mental health system. I also want to encourage you to connect them to NAMI. So NAMI is, of course, across the country. We know that family psychoeducation works, whether it's performed by or done by a mental health professional, or the family-to-family class within NAMI, which is taught by other family members. We know that relapses decrease when families know what to do and understand what's going on. And then just a reminder that families might feel isolated as well. And NAMI has support groups that are run by family members, and of course, ones for people who live with a mental illness as well. And, if you've ever been in a group where people have gone through a similar experience, it's like you don't have to start at the beginning, because though people in that group already fully understand what's happening and what's gone on with you. And so it's really helpful to have someone be like, oh yeah, that happened to me too. Here's what I found was helpful, right? Or just to be able to sit there and cry in a support group. And we've had family members that are kind of new to this come to a support group and they don't say anything for the first couple of weeks. They just sit there and cry. But the other thing that those kind of peer-led support groups do is they let someone know that they got through it. because that family member or that individual with mental illnesses, they're doing well and they're giving back to the community. And that just automatically gives you hope for the future. So again, just to kind of sum up, seek out families for their engagement and support. Ask them, as soon as you have permission to do so. Don't ask just once for a privacy release, ask more, and really understand the things that you can do under HIPAA that the attorney at the hospital is not going to tell you, but there's a lot that you can do under HIPAA. Wherever you can, include families in those team meetings so that they really understand the treatment options and how to help their loved one. And then just being available for questions. And again, it doesn't have to relate to their loved one, but they can ask broad questions about, so what does this medication do? What are the side effects? Things like that, which can be, again, very helpful. I really, again, no one walks alone. It is so important that people have someone to walk beside them. And I think when we think holistically about the person, not just, therapy, not just medication, but really holistically about, are they lonely? Do they have social connections? What is their living arrangement? Do they have stable housing? Do they have access to nutritious food? We need to look at people holistically, because just taking a pill doesn't cure schizophrenia, right? It takes way, way more than that. Andre Maurice said, without a family, man alone in the world trembles with the cold. The disease might hide the person underneath, but there's still a person in there who needs your love and attention. And so NAMI's motto, as long as I've been around, has been, you are not alone. And that's a statement that we need to make both to people with mental illnesses, but to family members as well. And we'll move to questions.
Thanks for an excellent lecture and for raising our awareness of the critical importance of families for people who suffer from serious mental illness. We're going to start with Q&A from the audience, and then we can take some questions from the Zoom audience. So please, and we'll pass around microphones.
I explained it that well.
Please don't be shy. I know you have questions and you all have families.
Oh, okay. So my daughter was recently hospitalized at a local psychiatric emergency unit, and she hadn't been hospitalized in many, many years. And I was so pleased really with the staff, and they did the verbal permission. We were there every day, and I was standing right there, and the nurse said, is it okay? Will you give permission, for us, to talk to your mom? And she said, oh, okay. And then the next day when her father joined, and he was kind of standing in the distance, and they asked about well, you gave permission for your mother, but how about your father? And she says, oh, I guess so. So it's in previous years, long before that, they were, and she was very delusional and psychotic. And she would not, in the beginning, give permission, understandably. But the social worker on staff was very communicative with us and saying, don't worry, we're going to keep trying. We're going to ask her. And I think, so we were up there that night, and she was still very, very delusional. But she agreed to sign the papers, and she went up to the front desk, and just to show you how delusional she still was, she said, and what's your name? But she knew, that we were mom and dad, so she did sign. So I just wanted to, reflect on that.
It's good to hear positive stories. One example I'll give you is I have a friend whose husband has bipolar disorder. And while he really is very careful and all of that, it seems like every couple of years he ends up in the hospital no matter what. And the last time he was hospitalized, she said to him, can we put something up on a Caring Bridge site for our faith community to know that you're in the hospital? And he's like, okay. She said, well, what would you like me to tell them? And he said, well, tell them that the decks of cards are so worn that you can't hardly play with them. And they don't have my favorite pop. And so every day for the next week, someone from his faith community showed up with a new deck of cards and his favorite pop. And it was the shortest hospitalization he ever had. And so, you know, we can't underestimate, right, the power of having friends and family care for you.
Question in the back?
Hello, my name is Gerald. I'm one of the third-year residents in psychiatry. And I really appreciated the comparison and contrast you made between how we enlist families on the psychiatric services versus medical services. I'm wondering, are you familiar with any health systems that do align more with the goals that you've set for enlisting family support while patients are admitted? If so, what is that health service and what are they doing differently?
Generally, no. We've seen at least things like visiting hours change so that they're way more open, just like the rest of the hospital, which is important. You know, people have jobs, right? They can't always come between 3 and 5 o'clock. So we've seen that happen, which has certainly helped. We've seen some hospitals actually just put outside the unit information about NAMI, you know, support group listings and things like that so that they know what's going on. Some NAMIs actually have they call it NAMI in the lobby. So they have a NAMI volunteer in the lobby near the psych unit to be able to kind of support families as they come in and out. But I would say in terms of widespread looking at HIPAA differently, I think it's very slow in terms of coming around, to be honest. And we have pushed some of the hospitals in the Twin Cities to think about, with technology these days, is there some other way we can have phone contact with people than what they're actually doing? What we have seen, and this is something that we didn't have to think about 20 years ago, right? But I don't know about you, but if someone asked me what my daughter's cell phone number is, I couldn't tell you because it's on my phone. I just click her name, right, to call her. And so people actually don't even remember phone numbers anymore. And so we have seen some hospitals at least put the cell phones in kind of in the nurse's station, kind of locked so they can't take pictures of other patients, but to be able to access them to look up phone numbers at least.
This question in the front.
Good afternoon. My name is Donna Lee Estes, and I'm the Executive Director of the local chapter of NAMI Rochester. So just so that you're all aware, we do have NAMI here in Rochester, and we offer support groups. We offer family support groups, peer connection support groups, and we currently we have already started a support group, a family to family education program, actually. And Pat, who spoke just a few minutes ago, is the facilitator and educator for that family to family support group. You can find information on our website, our telephone number, 585-423-1593. And our director of programs and education is right here today too, Beth Winslow D'Amico. If anyone has any questions, please feel free to reach out to us. Thank you.
Thank you, Donna. And a quick question. Can I see a show of hands? How many of you are familiar with NAMI's family to family program? For those of you that aren't, please go on their website and learn about it. It's 8 sessions taught by families, for families. If any of you are working with individuals and their families, please use Family to Family. It's an excellent resource.
There's a question up there.
Question, yes, in the back.
Thanks for a fabulous talk. I appreciated you sharing that families don't necessarily want to read the medical record or have their notes shared. They want to have a human interaction with their physician or treatment team. I'm wondering if you could comment a little bit more on what the experience has been in terms of whether communication has gone down as the kind of blunt sword of sharing the record has been a method of communicating with patients and families. And if you've observed any kind of maladaptive experiences or unpleasant experiences with the medical, the sharing of the medical record in terms of adequately communicating, making sure that there aren't mixed messages. I will share my full perspective on this, right? Which is that our medical record serves so many multiple purposes. And it is an inadequate way, from my experience as a child psychiatrist, to communicate with patients and with their families for whom we're not quite sure or even aware of sometimes who has the consent to experience those medical records. So for me, it's been an inadequate communication tool, and it isn't designed to be a communication tool, but I'll be curious what the families that you talk with and work with experience.
So I would agree, medical records, getting a copy of them isn't really going to help you understand. It really needs to be that kind of face-to-face interaction or over the phone, to be able to kind of, the medical record's not going to explain schizophrenia to you, right? It's not going to explain the choices between medications and why you chose one over the other. It's just not going to do that. And that's why, when we talk about HIPAA, it's like families don't want those medical records. They want you to tell them, right? What's the diagnosis? What are the treatment options? What is progression and recovery going to look like? That's what they want to know, whether it's an adult or a child. And even when someone's given a privacy release, usually we don't even see families still get the medical records. It becomes a permission to talk to the psychiatrist, or the therapist, but very few families have actually gotten the medical records in their hand because it's not what they want. Does that answer your question, or? I'm sorry, I couldn't hear.
We have an immediate release of notes.
Oh,
So as soon as you sign them, they're sent out by portal with a message saying there's a note. And she's also working in pediatric center. So parents get that message
Parents.
immediately.
I think even parents, and and I've been involved in the children's mental health system as well. Again, it's not that record that they're looking for. It really isn't, unless there's a summary of the medications, and the discharge plan can be a very helpful thing to have. But the rest of it and the notes, they often don't understand what they actually mean, and it doesn't help them know how to help their loved one. And that's really the problem. And maybe we need to develop a different kind of, record that gets released to families, more like a discharge summary in a way, except one that, where we don't use big words, could be helpful so that they're understandable and readable.
Down to our last couple of minutes, I'd like to take one question from the Zoom audience. Thank you for the lecture. I like the idea of involving families, but it's really a heavy lift. And I'd like to know what resources are available to support families along with NAMI so that we can address caregiver burnout. Essentially, who helps the families?
It's a great question. Other than NAMI, it kind of depends on organizations, in people's states. So, there's, Mental Health America, there is the Federation of Families, and then there's NAMI. There's not a lot of different groups out there. Sometimes insurance will pay for family psychoeducation and family therapy to help them. But often it really is that kind of peer-to-peer support and education that really helps people through this.
There's one other question. Are there still multifamily groups at Strong Ties? We offered multifamily groups from 1992 through 2019. We don't currently have groups, but we are in the process of developing a multifamily group in our young adults program.
Well, again, really want to thank you for inviting me here today. I hope you have some takeaways. I hope that you encourage family involvement in the future. And again, thank you so much. It was really an honor to be invited today.
Thank you.